So I guess to start off, I think that the whole title of this symposium is multimodal treatment, and that's something we all keep hitting on here, is communication. We need to communicate across the various branches. We all have different elements of care we provide, but none of those elements live in a silo. They all have to work together. So I have no disclosures. So the objectives of this talk are going to be to discuss the grading scale for instability in spinal metastasis, and to summarize the methods for determining surgical versus conservative management based on instability from imaging. I want to clarify, and I think Dr. Rines is going to talk in a little bit about surgical management of metastatic disease and touch on some other facts. We're looking at stability here. There is another element to deciding on whether surgery is appropriate, which I'll touch on, but again, this is really going to focus on the stability element of things. And then we're going to discuss a little bit when instrumentation is appropriate. So as an outline, we're going to go through a couple cases to sort of look at these concepts. We're going to look at the SIN score, which is spinal instability in neoplastic score, and look at some referral guidelines and elements of surgical decision making and some final conclusions and opinions. So to begin with, this is case one. It's a 65-year-old who had a little bit of neck pain, and sort of vague to me when I looked at all of his first imaging when I first got called why they were even imaging him, but somebody apparently had the right idea and went ahead and got some imaging. You can see a destructive lesion of C3 here with a little bit of superior end plate collapse, no real posterior vertebral body wall. The MRI correlates this with some element of tumor in there. His final workup, as we discussed, trying to get a diagnosis, was that he had a pretty significant pancreatic mass, which was identified during his CT scan examination. And so we're left with this. So I wish Hootie was still in here so I could hit him with all the questions he hit me with. Larry, just as we put this up here, what's your initial impression of the patient like this? Obviously, so calling it stage 4 pancreatic cancer with this lesion.
Pancreatic cancer, I'm actually surprised to see a metastasis from pancreatic cancer. Most people don't survive long enough to actually get spinal metastasis. So I'm sort of thinking about the prognosis in this patient. And I'm particularly interested in what the actual problem is and how I'm going to fix it. Why is this guy presenting? What are the symptoms that he's presenting? In a metastatic setting, what am I going to do to palliate the symptoms? And I'm a little worried with the pain as to what degree he might be unstable and whether that's going to get worse, and how am I going to fix that?
Good. All good points. I'm going to bring him back up a little bit later, so if you guys could hold on to those thoughts from Dr. Rines, we'll talk a little bit more about this. But excellent point in terms of what is the primary cancer. That's a very important decision-making point on him. So the next case, maybe we'll ask Rod to give us some thoughts on this. This is a 64-year-old who had breast cancer 10 years prior, had some severe back pain, finally went and after bugging their primary care doctor, finally talked him into an MRI for back pain. They figured, oh, your cancer was 10 years ago, we don't need to worry about that. And she gets an MRI, which is a little bit symptomatic, or which is a little bit impressive, and then this is her corresponding CT scan. Any thoughts here?
So I think I probably would do, full neuroaxis MRI. Full neuroaxis MRI, and then looks like she's got a lesion in the sacrum as well. And then, I think once you do the full workup and then probably need to restage her or stage her again, wouldn't be a bad idea to get a piece of tissue to see what this is, but clearly she's got some sort of metastatic process.
Good. And again, with her history, breast cancer is highest on your differential, but people can have ticks and fleas, so you always have to worry about, is there a second primary here? And I think that we've seen increasingly over the past decade, and I'm sure those of us who take care of these problems have seen more and more cases of breast cancer specifically with late recurrences. The old hormone receptive breast cancers were typically treated with 5 years of hormonal treatment post-diagnosis, and then they stopped. And I think that we're learning that maybe we don't know the right time to stop those agents. And it's rare, but it does happen. I have a 19-year post-primary treatment recurrence of breast cancer, so it happens. So let's talk about instability. So in order to talk about instability, we first have to define what is stability. So spinal stability, the seminal research on spinal stability was by Punjabi and White back in the 70s, and they defined it as the ability of the spine to maintain its degree of motion while simultaneously preventing pain, neurologic deficit, and abnormal angulation. So the Spine Oncology Study Group then went on to look at this concept of instability in the spine, and they defined instability along the same lines as the original Punjabi and White description, as the loss of spinal integrity as a result of a neoplastic process that is associated with movement-related pain, symptomatic or progressive deformity, and or neural compromise under physiologic loads. So these are people who don't, break their spine doesn't compress because they were in a car accident, they fell off a bridge. It happens under normal loads, and that's one of the keys to determining how somebody can tolerate certain amounts of deformity. Sometimes there's things that are subtle. That first case we showed, one vertebral body in a relatively stiff area of the spine may or may not need to be stabilized. Here is a little bit less difficult to determine stability, where one entire vertebral body seems to be missing in this picture. This was a renal cell patient. So again, what we're here to talk about is, when do we actually need to operate on these people? We need to figure out how to stratify out who are people at risk for instability and who aren't. So one of the first and most straightforward surgical indications, and probably the best evidence, is from Dr. Patchell, who unfortunately, as we mentioned, isn't able to be here today. Symptomatic cord compression. So he did a randomized controlled trial, which is truly an excellent effort on their part to try and provide some evidence-based medicine that symptomatic cord compression from non-highly radiosensitive tumors, so going back to one of our case examples earlier, that excludes lymphoma because that's a highly radiosensitive tumor as well as chemosensitive, should be treated with direct decompression. So symptomatic cord compression is a straightforward indication. So we are not going to talk about that here. We're going to look at the other side of it. So spinal stability, spinal instability. How do we know when somebody's unstable? So, the one on the right, I know it when I see it. It's pretty clear that that's unstable. But not all patients are quite this straightforward. It's a very ill-defined thing. We think about, should we be doing prophylactic surgery in more people, less people? How do you pick who to do it on? How about some of these minimally invasive techniques? We look at vertebral augmentation with cement, either kyphoplasty or vertebroplasty. Certainly, if it's easy to do, maybe it's just safer to do that for people. Well, we'll show some examples of that as well. The orthopedic oncology literature is actually very nice in this regard. So they have a couple of studies that were done by Drs. Merrill and Harrington, 1 to 2 decades ago, 3 decades ago now, looking at long bones. So the long bones are what hold us up, and we've defined criteria: how much destruction of the bone, how much pain, what type of lesion is it? Is this destroying the bone? Is this making bone? And then they gave us some good guidelines. And I think the Spine Oncology Study Group really sort of recognized some of the advantages of this and tried to look at a way to figure this out. Because in the spine, there has not been a consensus. And we really basically just extrapolated from the trauma literature, trying to provide some insight and guidance. So prior to putting together the SIN score, Dr. Failings and Fisher and the Canadian folks did a systematic review of the thoracolumbar spine. That's one of the highest stress areas of the spine and a very common area for spinal metastases. So there was a lot of literature. They actually found 39 studies looking at spinal stability. They ended up meeting inclusion criteria for about 25 of them. I think the Tanichi article is probably the most quoted of them all from Spine in 1997. But looking at these 25 studies, they provided some guidance, but I don't think they really gave us any specific rules. Problems with them were they were a little bit retrospective, most of them. There's no control for extrinsic factors such as bone density, body habitus, and there was significant heterogeneity in the tumor types that we were looking at. So they talked about osteolytic tumors just like they talked about blastic tumors. And I think that that's an unfair way to try and systematically evaluate this process. So what they were able to determine and conclude that there were some important variables that we found throughout all these articles that seemed to be important. Those being anatomic issues such as the tumor size and location, force characteristics, bone density, again the blastic versus lytic lesions, as well as alignment. So their ultimate recommendation from this review paper was that a functional scoring system will have to integrate some expert opinion into this. It's not going to be something we can purely do from the literature. You're not going to have a randomized prospective study without starting with something. It's interesting and actually nice if you look historically, because I think one of my mentors told me that if you think you have a new idea in orthopedics, you're just unfamiliar with the German literature from 30 years ago. Jens would appreciate that. So one of what Dr. Merrill did actually, when his study, he actually published 2 papers. His first paper was a retrospective review looking at, here's a bunch of people who did break, what were the risk factors for breaking, and where do we think that level of suspicion needs to be raised. So he created a scoring system retrospectively, and then he employed it prospectively to see how it worked. And I think that that's one of the advantages of this same rationale for developing this scoring system. So the Spinal Instability Neoplastic score, again, this was published in 2010, and Dr. Rhines was here. Jens, are you in this? I don't know if Jens was part of this. So what they did, the Spine Oncology Study Group used an EBM process using a modified Delphi technique where you go through and look at what you think is important, and then everybody looks at it. And it is a systematic way to use expert opinion, and it's utilized in a lot of different ways. It's actually fairly solid scientific process. So what did they do? They created the score, and then not only did they create the score, then they said, all right, now let's give some case examples. So they took their own score that they determined, and many of the same authors looked in this first one in JCO at how reliable and valid is this if we give ourselves cases and we go through them and measure them. And that was pretty good. Then they said, all right, well, we're trying to create a communication tool here, so let's have other people do it. So they had some radiologists do it. And then they said, all right, well, radiation oncologists are important too. Let's have them do it. So the same process they went through and were able to document in all of these studies that there was fairly high reliability. So they'd created a scoring system that was user-friendly enough that everybody could work with it, and that would be a communication tool to enhance the treatment of these problems. So what is the SIN score? So it's basically a classification system that's based on both patient symptoms as well as radiographic criteria. The elements of it are the spinal location of tumor, type and presence of pain, bone lesion quality, spinal alignment, as well as the extent of vertebral body collapse and posterior lateral spinal involvement. So again, this is meant to be a clinical guideline, which we want to use this to communicate amongst ourselves. We want to try and figure out who needs surgery. So many of these operations, as you guys have seen so far today, and we'll show a few more examples of, they can be fairly invasive for people in many cases. So you want to pick the right people. The decision for an operation is many times more important than the incision. So we want to make it easy to use. You want to, a spine surgeon has a different concept of how to look at a CT scan than a medical oncologist, but you need to have a good language that you can both speak. It should be comprehensive and focused. Again, with some of the prior studies, there was a lumbar system and a cervical system and a thoracolumbar system. This system was designed to be universally adaptable to the entire spine, which is another nice advantage of it. And finally, to guide treatment, it's a scoring system. So patients with a score of 0 to 6 were deemed stable, 7 to 12 potentially unstable, and 13 to 18 as unstable and needing intervention potentially. So we'll look at the different components here with some pictures to try and understand what do these things all mean. So the SINS component score for spine location. So spine location, the highest score was given, so a high score is bad if you remember what we just went through. So the highest score is given to junctional areas. where the head attaches to the spine, occiput to C2, where the cervical spine meets the thoracic spine, C7 to T2, the thoracolumbar spine. So if you know about spine biomechanics, these are the areas of high stress. That's why they get the higher score. The mobile spine, sort of mid-cervical spine and mid-lumbar spine, are your next highest score, because there's some element of motion here, but not quite the stress of these junctional areas. And you can see a couple examples of these. This at the bottom right there looks a little bit like Dr. Mendel's chordoma he showed. Unfortunately, in this case, it was myeloma, so a little bit different treatment. And then the semi-rigid spine, which is where the ribs are. The ribs provide some intrinsic stability to the spine. And then the truly rigid area, or the low sacrum, which is no real support for the spine itself. And here's some thoracic lesions as well that you can see. So the next component is going to be mechanical or postural pain. I think this is something that is probably disregarded universally in the spine. Dr. Chapman and his teaching to me in trauma really reinforced the need for upright x-rays, because that's the position that we all live in. Somebody feels great laying down after they broke their back, that's one thing, but if they stand up and they're miserable, it's a different thing. So you want to see, what do they look like and what do they feel like standing up? So this is a functional pain measure. So people who basically have pain that is only relieved by recumbency and exacerbated by movement, that would be considered a pain score of 3. The occasional pain you can look at as sort of a little bit less, in terms of 1. This happens to be a patient we'll go over a little bit more later, who had, you can see a degree of kyphosis there in the center picture, and he had relief with laying down, so he actually did stabilize his spine to try and give him some symptomatic relief. And we'll talk about his case in a little bit, because I think it's a good illustration of some minimally invasive techniques. So bone lesion quality. This again is coming straight from the orthopedic oncology literature and the scoring system of Dr. Merrill. And the most unstable is going to be the lytic spine. You can see on the left here, this is a facet joint that is basically non-existent. There's no remaining cortices there. It's completely replaced with soft tissue, and that's going to be very unstable. The picture in the middle is a patient who actually has had some systemic treatment from breast cancer and kind of has a little bit of a mixed mottled appearance to their spine. So that's not normal bone, but it's not the same as that bone on the left, that purely lytic bone. Then on the right is what we would describe as blastic bone. So this is most common in prostate cancer, but we can also see it in breast cancer, and we can see it after treatment with systemic or radiation therapy. So it's that very hard, white, sclerotic bone. You can imagine how it's almost like chalk. So it can be brittle like chalk, but it tends to be fairly strong and low risk of fracture. You can see the patient above that has it basically riddled throughout their pelvis. So spinal alignment, another important factor. So one important factor in this spinal alignment is on upright radiographs. So the calls I tend to get, and I'm sure many of the other surgeons in the room, is patient got a CT scan for staging purposes and there's some compression there. Is that okay? Well, my first answer always is get an x-ray. Tell me how it looks when they're in an upright position, because going back to the pain thing, if they feel fine when they're lying down, they don't when they're upright, that probably means there's some movement we're not seeing. And you have to remember that all those CT scans, 99% of your MRIs, they're all done in the supine position. So you do need to know the patient's baseline alignment. There are people who have some cervical kyphosis, or the forward bend as their baseline. But what you want to look for is their significant change in alignment. So kyphosis and scoliosis are sort of your intermediate risk. But if you have somebody like the patient on the right there, you can see has true subluxation there between C2 and C4. And you might think, oh, well, if I see that, they're going to come in and they're going to be really hurting or unable to move or paralyzed or something. That lady had just driven up from Atlanta and went to her chiropractor and then came to see me the next day and said, yeah, they told me there was something wrong with my x-ray. So just because the x-ray looks ugly doesn't mean that they're not pretty functional still. And the patient on the left, you can see it's a little lower down at C7. He has kyphosis there through a compression fracture. There we go. So vertebral body involvement. So as you might imagine, how much of the body is gone, how much of the quality of the bone that's left will introduce some element of stability. So if you look at the patient on the left there, they have fairly sizable hole in the vertebral body, but the bone around it is fairly normal looking. In fact, it's maybe even a little bit sclerotic. So that patient is probably going to have a score of 1. So they don't have any collapse, but they have maybe 50% of their body involved. So there's some risk there. But then you look at the patient on the in the middle there, and there's much more significant amount of vertebral body involvement, but they still don't have a ton of collapse. So he might, despite all those lesions, still only have a score of 2. I'll use that as sort of a point to jump in, that one limitation probably of this score, of the scoring system, is that it doesn't really account all that well for multifocal involvement of the spine. It was sort of defined in an isolated environment. Dr. Rhines, any comments on that? Is that an accurate statement? I think you get into trouble. You can't just give them a score for one level and then add it to the other score. So there is some gestalt when you look at these things that you have to have some judgment. And then the one on the right obviously has significant collapse at 2 adjacent levels. So there's some significant stability issues. And really this score is really a surrogate to describe the contribution of the anterior and middle columns to stability. So then moving on to the posterior column. So again, these are the 3-column theory from Punjabi and White, looking at stability of the spine. And we know that this posterior lateral complex, which involves the facet joints, costovertebral joints, is very important to the intrinsic stability of the spine. And having one involved, such as you see on the left, can certainly be a problem. And that's actually, incidentally, the same patient that we just saw in the lytic sagittal view that we saw. So pretty sizable lesion there. But the other side is totally normal. It's when you lose both of those joints, which, if you remember, this one on the right is our case example from number 2, where they start having significant involvement. And this group decided that this bilateral involvement was actually more than a doubling effect, so they went from 1 to 3 in terms of scoring there. So let's get back to our case here to talk about things. So we have an upright x-ray of this patient, which we looked at. And if we're going to assign a score for location, the C3 to C6 region, we're going to give them a score of 2. Pain is always arguable. Again, this person didn't have real persistent pain. It wasn't clearly relieved by recumbency, so I'm giving them a 1. We could argue about that later. As far as the lesion goes, if you remember the CT scan that Dr. Rhines was describing to you, it is lytic, so we're going to give him a 2 for a lytic lesion. Alignment-wise, this is an upright x-ray. To tell the truth, and my little bit of poetic license here, he is in a collar, but that was to help him in terms of his comfort. And because we knew he did have that lytic area, we wanted to try and protect him a bit. But in terms of collapse, he has less than 50% collapse. So we'll give him a score of 2 there. Posterior involvement, he had none, so he gets a score of 0. So when we add those up, he has a total score of 7. So that would be in the potentially unstable group. Completely reasonable to get a spine surgeon involved to help make some decisions on this. So when I met him and talked about all this with him, he felt okay in the collar. Again, going back to the point about what his primary was, pancreatic cancer has a low probability of survival. It's, again, very unusual. I mean, I take care of thousands of bone metastases, and I maybe have 4 patients who've had metastatic pancreatic cancer to any bone. It's just very unusual. So his life expectancy de novo would probably be 3 to 6 months maybe. So we said, you know what, let's let you go through some chemo, see if we can do anything for you. We're going to put you in a collar, and we're going to radiate your neck. So he tolerated that well and actually was symptom-free. I saw him at 3 months, and he was out of his collar. His x-rays were normal. He felt fine. He was, doing some things he wanted to whenever he wasn't getting chemo. And I don't remember off the top of my head what marker they were following, but one of the serum markers for pancreatic cancer that they were following was actually improving. So he seemed to be having a response at 3 months. So everybody's kind of happy. We're patting each other on the back. And I said, cool, I'll see you back in 3 months. Let me know how you're doing. And he showed up on my door at 5 months. And at 5 months, we took another x-ray. And the good news is he's still alive. The bad news is his spine has started to fall apart a bit. So we are going to revisit this score. So now we get to the pain score. We bumped him from a 1 to a 3. Alignment-wise, he has clear subluxation. So again, the word subluxation, for those of you who aren't used to looking at spines and alignment, means when instead of two vertebrae being aligned, that they have slipped. So you can see between that second vertebrae, and I can point right here. So between the second vertebrae, the posterior vertebral body line, and then the third, there's a good half a vertebral body step off between those two. And then his vertebral body involvement increased to 3 because now he has more significant collapse of that third vertebrae. He actually, when you look at the CT scan, now has a little bit of posterior involvement on one side, which leads us to a total score of 15, which transitions to him to being unstable. So now we're looking at a guy who has actually responded a bit to treatment and is doing okay, but is now in a place where he has too much pain to do things functionally. So we had a long discussion, talked to his oncologist. Again, you got to communicate with everybody. So I talked to his oncologist, reviewed the radiation plan to figure out what exactly they had radiated to make sure that we radiated what I think they radiated, and decided to proceed with surgery. So again, using a little bit of poetic license, he did at presentation have a small lesion in 5. That has actually progressed a little bit here too. And again, the lesion in 3 in the posterior elements was bigger. So, I think that we were looking at a little bigger operation for him. So we ended up doing a 3-level anterior corpectomy with a cage in there, and then backed him up posteriorly with pedicle screws. One thing I think to remember in the cervical spine is people tolerate cervical operations a lot better than lumbar and thoracolumbar operations, and you can get them over. And this guy was in the hospital for like 3 days after this operation, so it was not too bad, and had basically 100% pain relief from his pre-op axial pain that he had. And his one goal was to play golf, and he was back playing golf at 6 weeks. So case 2. So this is turns out to be sort of a tale of woe. This patient was actually awaiting, I'm sure that if any of you know what you're looking at here, you see some things that aren't supposed to be here. There's some little white things right here. That's cement. So the story is that they had an appointment at the cancer center and were sitting at home one night and saw this ad for Cancer Center Treatments of America and thought, wow, they can cure my cancer. We're going to go there. So the next day they got in their RV and drove to Atlanta. So these treatment centers have sort of proliferated around the U.S. and for good or bad, they're now close enough to us that people can drive. So they went down there, saw them, repeated all their scans, found out that maybe it was recurrent breast cancer. She had a couple of liver lesions and small, tough to biopsy, and then multiple spine lesions. As Dr. Screen had clearly noted, that sacral lesion, you know how I sort of hid it here so you couldn't see it. But it was actually a very sclerotic lesion, so she sort of had a mixed picture here. So they did a biopsy of her while she was down there and said, well, since we're biopsying, you're going to have a needle in there. We're going to squirt a little cement in there because that's going to make you feel better. And anyone who does any kyphoplasty or vertebroplasty knows that she meets pretty much every criteria for contraindications to that procedure. So we talk about people doing things they shouldn't do. They said, wow, you hurt a lot more now afterwards, and you have horrible left leg pain and groin pain. You should go back home and go see a surgeon. They didn't even have anybody who could take care of it there. So they put her in her motorhome in a wheelchair, and then told her to go to the hospital when she got home. So she did. She came to visit us. And when we just look at her, we'll ignore that part of the story because it gets better. And she had a score of 14. So by all the criteria we discussed, which you can see there, I'm not going to go over them step by step, she was in the unstable criteria. So she probably needed an operation. She had no major systemic disease. One thing they did nice for us was they got a biopsy, and it was breast cancer. But so she came in with this very severe leg pain. It was new since the procedure that she had. And being at this level, that fits with sort of an L3 radiculopathy. So it made it, seem like, okay, I think we know what the problem is. As we finished her staging and her bone scan, she also had a big lytic lesion in her proximal femur on the left mid-thigh. So introduced another potential issue of which one was the symptom. So again, taking a good history and physical and looking at the timing of onset, we decided this probably was coming from her spine. She was not tolerating this current status, and we decided to proceed with surgery for her, which was removing all of that cement and doing just an intralesional procedure on her with some anterior column support there. And she actually had fantastic pain relief and is doing well. I actually just saw her on Tuesday. She's about 6 months out and doing wonderfully and responding to her systemic treatment as well. So, talking about communication, what is this score used for? So it's, again, a referral guideline. The stable spine, medical treatment or radiation referral is appropriate. You don't necessarily have to incorporate a surgeon. If you have somebody who's in your cancer center who you can send an email and just have them glance at it so they're familiar with the patient, completely reasonable. But if not, probably easy to just go ahead and treat that patient. 7 or higher, we do recommend, and the criteria do recommend surgical consultation. So now we look at surgical decision making. Again, this is not just about stability. If you decide to move towards surgery, you have to think about the whole picture, think about the whole patient. So I think this is something that I still use, really on a daily basis. I don't calculate it to meet a score on everybody, but this is the basis of my rationale and my thinking about patients with spine tumors. So stability is important. So the SIN score is very, very important and an element of this. Spinal cord compression, which again we mentioned earlier, is another very important element to discuss. Then you have to think about tumor histology. You saw in that first case that we did some of our decision making based on his histology and his prognosis being in the shorter realm there. So this scoring system is nice. It's very simple. It looks at the type of primary tumor. It looks at the presence or absence of visceral metastases and the number of bone metastases, and then goes on to give you a prognostic score, some treatment goals, and even a discussion of what surgical strategy should be potentially employed. So I think the most important thing about thinking about surgery is you got to remember these big principles. The principles are to preserve or restore neurologic function, to maintain or restore spinal stability, to provide pain relief for the patient. And all of these different scoring and staging systems can really be complementary and facilitate communication between practitioners and help guide decision making and referral for these patients. So when we talk about surgery for stability, so again, I'm going to get away from the neurologic compression, because I think when you have epidural spinal cord compression that is symptomatic, that needs a formal decompression. But we're just talking about stability here. So there are some special instances where we can do some more novel and maybe more modern treatments for things. So open surgery, you've seen lots of pictures of that so far in my talk about about open surgery, which is really my primary option for things. But on occasion, you see somebody who has a unique circumstance. Somebody may have pure anterior column loss with a lytic lesion from multiple myeloma, which may have been easily treated with chemotherapy and/or radiation, but they have a true anterior column instability with nothing else. So in those people, I think that vertebral augmentation is a completely reasonable and rational option. Myeloma, it's really an excellent option for. I would strongly caution against its use in solid tumors, especially de novo solid tumors that have never seen any treatment. I think there's some pretty good literature, especially in breast cancer, about stereotactic radiosurgery and then prophylactic vertebroplasty or post-treatment vertebroplasty. There are some new advances in the realm of intralesional procedures such as RFA. I am not on board with that yet. I think it is something else to consider, but I think that that post-radiation group was actually very nicely elucidated, and this was the stereotactic radiosurgery. I think the Memorial group in JCO in 2009 found about a 39% incidence of collapse. So their thought was to prophylax this collapse by stabilizing the bone after treatment. Very reasonable. And this is a case right here where I did vertebroplasty for somebody with just mechanical insufficiency of the anterior column and myeloma. Here's another case. Again, I mentioned this case when we were looking at upright positioning and pain relief. So this patient had advanced bladder cancer, had this MET identified in his L3 vertebrae here, and was radiated and had some initial improvement after the radiation, but then started having some instability symptoms. And he was to the point where he actually couldn't even get to and from the hospital, to and from the infusion center to get his chemotherapy. So the medical oncologist called me and said, hey, I can't treat this guy. I can't get him into the chair. I can't get him here. He said he feels fine when he's laying at home on his back, but he can't get in a car. He can't come here. So to me, lights start going off, and I said, all right, let me see this guy. I got some ideas. Maybe this is a stability issue. So we had his CT up before, which showed a little bit of collapse there, but then when he stand him upright, he developed significant kyphosis across that segment. And he, to my, in my office, same history, I can lay down fine and I'm fine. As soon as I sit up, I'm miserable. So we actually discussed a pure mechanical option for him, because they didn't really want him out for a big operation, corpectomy, fusion, where you might be out of commission for 4 to 6 weeks. They wanted him back so he could give him chemo as soon as possible. So we actually did a percutaneous fusion. So this is, 4 vertebrae instrumented, 2 above, 2 below. It's just percutaneous screws. And you know what? That was our goal. So understanding what your treatment goals are is really important when you're dealing with these things. We got him to what he needed. He could sit up, he could get in his car, he could get to chemo, and that was our goal, and that was what we were able to achieve. So complications are everywhere in this group. Patients are frequently sick, frequently immunocompromised, or just nutritionally compromised. So I think you really need to understand what you are operating on. Going back to the first talk about the en bloc spondylectomies, and that knee-jerk reaction to just operate on something right away. Lay down and let the feeling pass. Think about it. Be thoughtful. Make sure that you understand what you are operating on. So if I had done a big operation on that guy we just looked at, and he was off chemotherapy for 6 weeks because he had some complication and before he was finally ready to go, and in the meantime his cancer had progressed to a point where he was untreatable. So think about why you are treating them and what your ultimate goals are. Think about your timetable. People with cancer care about their timetable. And try and optimize your patients. Again, we talked a little bit during that last cadaver section about chemotherapy. Again, Avastin is really terrible drug for healing. So off that as long as possible, if possible. And then you can see here, this is one of my failure cases, where this patient had very severe cervical thoracic kyphosis, and we just should have kept going down lower on those screws. So the good news is, if somebody else does that and it shows up in your ER, you don't need to find an old op note to find out what kind of hardware they put in, because you can actually just look right there and see the screws. So you'll know exactly what you need. To the right, you see another. I've already showed you one tale of woe about kyphoplasty, but this is another one. This is a patient who had renal cell carcinoma, had no posterior vertebral body wall, so there's no protection for the spinal canal. So the radiologist said, oh yeah, we'll just put a little cement in there, they'll feel great. Technically put in a big blob of cement, but this is a solid tumor. Again, this is a great example of what happens, is this solid tumor just gets pushed back and into the cord. So then the patient did not get any improvement. In fact, got a little bit worse. Luckily, that person didn't have cord compromise from this, but they did end up needing a more significant operation very soon thereafter. So, in conclusion, I think the Spinal Instability Neoplastic score is quite useful for predicting instability. It may be in the future that for major cancer systems, healthcare systems, that this is something that we should be recording and keeping track of, and try and be a little bit more systematic about how we do things. I think it's one of the biggest benefits of it is it is a nice communication tool, as I've tried to hammer home here as we've talked. In terms of how do you fix these people when you have to take them to surgery, I think that rigid spinal instrumentation is really the rule. When possible, anterior column support will help improve the longevity. These people generally do not heal their fusions, as in the primary sarcomas, where that's such an important thing. They don't heal because of longevity issues. They don't heal because of radiation issues. So any true structural support you can implant is better. In a similar vein, instrument longer than shorter. And direct decompression, again, along with the Patchell principles there. And really, decompression alone, a pure laminectomy, as we saw in that first case from Dr. Mendel, is really, I think, an antiquated procedure and should almost never be performed. And there are some minimally invasive options that are possible. You just have to be thoughtful and understand what you're treating. And I think that's it. My one Carolina Panthers slide.